appear up in the upper left-hand side of your screen. Please take note that there is a chat box and a Q&A box at the bottom of your screen. If you have comments, please feel free to put them in the chat. If you have questions for Dr. Mona, please put them in the Q&A box, and I will be monitoring both of those. And if it seems like a good spot to stop Linda, to ask her a question, I will do that. A lot of times folks have questions that then get answered a little bit later in the presentation, but we'll do our best. And then of course, Dr. Mona is a fabulous consultant and I'm sure would be available if we are not able to get to all the questions after today's webinar. So without further ado, I'm going to introduce our speaker. Dr. Linda Mona is a clinical psychologist for the VA Long Beach and has been so for the past 20 years, which is impossible because she must have started when she was in grade school. She's currently the clinical director for the Spinal Cord Injury and Disorder Psychology Clinic. Her work has prioritized disability affirmative psychological services and sexual health assessment and treatment for people with disabilities. Dr. Mona is actively involved in VA psychology training, both locally and nationally, to ensure that disability, diversity, and identity is part of the work of future generations of psychologists. Infusing disability into psychology, diversity, education, and training has been one of Dr. Mona's career passions. She's challenged traditional medical notions of disability by reframing this identity from a multicultural lens. Through national psychology professional service roles, she's been successful at promoting disability consciousness through her expertise, social justice advocacy, and her own lived experience as a disabled woman psychologist. She has facilitated over 100 trainings, has numerous publications focusing on disability, sexuality, and disability diversity. Dr. Mona's work has also been recognized in mainstream media, including the Canadian Discovery Health, PBS, NBC's Today Show, and Self Magazine. I also want to say, obviously, she's a distinguished psychologist. She also serves as one of Division 18's representatives to APA Council, and she's quite simply impressive. So with that, I'm going to turn it over to you, Dr. Mona.
Thank you, Gail. Thank you for that introduction, and hello, Division 18 family. I am so happy to be with all of you today, and I am not seeing the comment box, and Gail's going to be monitoring that for me, so I'm just going to head right into this. I'm happy to be answering questions as we go along or waiting to the end. You all know how to find me. I'm going to remind you at the end. I'm happy to consult with you in any way that I can or help you in your practice or whatever you do as a psychologist. So why are we talking about these issues? Let me try to advance my slide here. Okay. Here we go. I guess I'm using this. What are we talking about today? Obviously, we're talking about disability diversity. Some of you might be newbies to this, and some of you might have heard me talking about this for the last 20 years. And that says something. We have to continue to talk about it because there's still something that the field is not getting around disability diversity and how we actually integrate that experience into our work, no matter what we do as psychologists. So we usually talk about language, semantics. Do we talk about people with disabilities, disabled people, you know, person first identity, or identity language. Some of this, again, might be a review for you, and some of you might have not heard of this at all. Traditionally, psychologists have been trained to use person-first language to say people with disabilities, making sure that we see people first and their disability second. Many of us in the community have objected to that rule within APA guidelines and just with all of the work that we do, indicating that many of us are very proud to have that identity. Not an easy identity to have, but one that really makes us feel the way that we do. So there's several different articles I'm happy to point you towards with long discussions definitions around person first and identity first language. Today, you'll hear me saying person with a disability, people with a disability, disability community, disabled people. I use those things interchangeably. That's what I'm comfortable with. And what you need to keep in mind is what you want to use when you are educating and teaching and training, and what you want to use when you're with your clients, if you are clinicians. And that is, we always match someone's language. So you all know that already, but I just want you to have that in your head as we're going through today. We're going to talk about definitions of disability, disability in psychology, cultural competence. We're going to, spend a little bit of time on clinical work and how we integrate this knowledge into our practice. But I also just want you all to be thinking about this, no matter what role you have. How does this affect you? How does disability, working with people with disabilities, as your client, as your student, as your research participant, as your colleague, how do these things change as you think about these things? So again, person first, prefix first doesn't matter. Disabled, please say this word. we want you to just say it. It's not ability status. We want to say disabled. There's been this belief that we somehow need to take away this awful experience about what it means to be disabled. We need to detach people from that experience. We really need to just say the word. And along with some other colleagues, we had an article come out last year, which is hashtag say the word. We need you to say the word. We need politicians to say the word. We need psychologists to say the word. We need everybody to say the word so that we realize what we're talking about. And it's not just about quote unquote ability status. It is about everything that goes into being somebody who lives with a marginalized life experience, oppression, discrimination, and all those other things as well. So why are we having this discussion? We're having it because cognitive, behavioral, emotional, and physical components of trauma, injury, and disability affects every part of someone's life. It affects everything in their healthcare. It affects every interaction that they have. So you coming to this role, how much do you care? I don't know. You're here for some reason. You're either here because somebody requested that you're at this presentation, you have interest, you do care. You might be fearful of the topic. We scare a lot of people. I'm not really quite sure why, but disabled people scare a lot of people. And I think most of that, that is some disability humor. Most of that is around people's discomfort about not knowing what to do with somebody who thinks differently or who moves differently, and how that affects their interaction. I think most of it comes from that discomfort and not wanting to make somebody uncomfortable or hurt their feelings or do something wrong. Remember, as we go through all of this, and as we're talking about marginalized groups and working with people from different backgrounds, the only mistake that you can really make is not asking the question and not addressing it. And if you don't do it the first time, you usually have another opportunity to go back and repair that. It is your ethical responsibility. So as you start to think about these issues as a clinician, as an educator, all of these things, all these great trainings that you've been to, you know how to implement a certain intervention. You only know how to implement that well and with true efficacy if you've thought about people who have different identities. And if you don't know any of this at all, you're going to get it. You're going to get some today. You're going to get thinking about disability different today. And if we achieve that goal, I will be happy with that. And I hope that you are as well. I want to start off with kind of this APA definition of multiculturalism and diversity. Years ago, right, we used to talk about definitions around multiculturalism as this long laundry list of identities. And I think we did that because we didn't want to leave anybody out. And if you see this original definition, we look about multicultural and diversity encompassing multiple dimensions that comprise identity, including, and then we start in, right? Race, ethnicity, language, sexual orientation, gender, age, disability, class status, educational, religious orientation, and other cultural dimensions. That and other used to encompass disability. That's tagged on because we want to make sure that we're not forgetting people in our conceptualizations. And as we look into a more data, more recent kind of view of multicultural, some APA really has broadened this out about equality or condition of a society in which different ethnic and cultural groups have equal status and access to power. So here we're talking about power, privilege, as it relates to identity and characteristics of how people are in the world. APA, has done this multicultural and diversity summit every other year since 1999. And I was at that first one in 1999, which it was all about race and ethnicity. And it was called Diversity and Multicultural Summit. And I was confused. And as were many other people, I think there were 2 papers on LGBT issues, but mostly it was about race and ethnicity. And my point at that meeting in our town hall was, why don't we just call this a race and ethnicity conference? Because I think that's fine to do that. But if we truly are going to be talking about this, let's raise the bar a little bit and let's really think about what we in psychology think about as multiculturalism and diversity. This all starts with self-assessment, and psychologists love to throw that around. You just need to self-assess, but we don't really say how we do that or when we do that, how important it is. It's not like we're not busy, but when we self-assess, we're really looking or evaluating our actions and attitudes and performance at our job or whatever task it is in relation to an objective standard. So what is your objective standard around disability? And I think that you need to answer that within your professional role. And if you haven't thought about it, it's okay. Give yourself permission to not have thought about it. It just might not have been on your radar. And that's the field's responsibility. And that's, supervisors' responsibilities and everybody's a shared responsibility in our field to bring this really to our attention. So let's begin. We're gonna do a mini exercise here. And I want us to think about it. So if we were in person, I would be saying clap, tad, nod, whatever. But I just want you to think about this, just reflect. We're going to go through these really quickly. So if you've ever felt sad when encountering a person with a disability, I have at times. Have you ever felt slowed down? So for those of us who work in very fast-paced settings, I know working at the VA hospital, right? Like I'm just zipping around in my wheelchair all the time. And we have patients who are slow. They're disabled, just like me. And I have to check myself. I have to say, okay, you need to slow down a little bit. You don't really need to be speeding around somebody who needs the extra time. But do I feel slowed down? Sometimes I do. Have I felt inspired? Have you all ever felt inspired by a person with a disability? I'm putting that word in there because that word is this pop word in the community, because it is often something that we get told a lot. Oh, you're such an inspiration. And it's part of our disability humor. We actually say that back and forth to one another because many times people are inspired by things that we don't feel inspired by, like living our usual life, going to school, going to work, having children, participating in regular life activities. Disability life is hard and it's a struggle, and this is not an easy experience to live with, but to constantly be reminded that you're some kind of anomaly, and that it really kind of informs us that people really just don't understand the community and the culture at a larger level. I will tell you, I've been called to task by some people who have called me inspirational, and I've had to self-assess and think, well, my work has been inspirational to some people. The way I've led groups has been inspirational. So, we all have our ways of needing to check ourselves, and that's certainly been one for me. I want you to think about your important identities. I want you to consider who informed you. So think about your earliest memory. Who informed you? Who was the first person with a disability that you have seen? What were the messages? Was it a parent or a guardian who pulled you away from somebody and said, don't talk to that person or leave that person alone? And what's your relationship to disability right now? Is it your clients, your students, your trainees, your patients? Somebody? Is it me? Am I the only person that you know? Think about that for a minute. And if there's anything salient that anyone wants to shout out, I'm fine with that. If anybody has had a revelation about the first message that they received. I'll just pause for a minute. If not, I will keep going. Okay, I'll keep going. So as you think about disability in your personal and professional roles, I want you, and I always use myself as examples because I really believe in a narrative, and I believe that storytelling is powerful for people, and showing pictures of other disabled people would not feel right to me. So I do include pictures of myself. So I want you to think about your professional. If you saw me in the pre-COVID world, you would see me training, you'd see me running around in my chair and discussing issues around diversity, disability, maybe sexuality and disability. For some people, they haven't seen a lot of presenters who use wheelchairs. It's different, right? The way I walk is different. And so although you might not be you might be challenged by a different presentation, you might not be so surprised, right? You might not be surprised to see me in a medical setting behind a nurse's station. Although people who are not used to working with colleagues with disabilities are surprised by that sometimes, because they will want to know. I've been asked, can I help you? Assuming that I'm a patient who's behind a nursing station. Now that I've been there 20 years, that doesn't happen so often, but it did happen early on. Might you be surprised that I'm a mom, right? So, and I always have to include this because this was one of the most awesome memories of my life. And I have been privileged to receive so many different awards for the work that I have done. And one of the awards that are probably the award that I am most, impressed by and excited by was a Working Mother of the Year award, because as a disabled mom, and knowing as what I fought for to have that presence and that title in my life, and going to New York and receiving this award was this amazing thing. I do have permission from my kids to use their picture, but it's only if I show you what they look like now. Because they are much bigger now, and yes, they're football players. And so this little disabled woman gave birth to these huge athletes. That does happen. That's another thing that challenges people's belief systems, but they're 17 and 15, and the joy of my life. So people who also might not be surprised by me as being an advocate receiving awards, what they do get surprised by, I have chronic health issues. And so I go to physical therapy. I do these things. That is part of my life. And this is what makes disability different, that mind body difference in some way, the accommodations that I need or anybody else needs. So I took this picture of myself at a physical therapy appointment because I had a trainee call me and I had to do some quick supervision, and I was doing it with hot packs on my neck, and this challenges people, right? And it worries them, and people worry about their colleagues, and what does that mean for them to be able to deal with these things? It's part of disability life. It's part of disability life. What are the societal beliefs around disability? Stereotypes that disabled people are they're bitter or they're angry with life. The attitudes from non-disabled people around disabled people usually are negative, or they're heroic, as we mentioned earlier around, it's really awesome that you got out of bed today, or that you did something on your own, when it's something that you actually do every day. And that's only a very small part of what you do. And there has been much more discussion in the last 15 years about hearing from the voices of disabled people. That's been done less by psychologists and more by medical anthropologists, and more by people who are involved in disability studies. Psychology can learn a lot from looking at that work and looking at the narratives of disabled people so that we learn more about their experiences. Factors that tend to affect attitudes towards disability is the person who's seeing that person, the characteristics of the person with a disability themselves, and the characteristics of the disability, and the context, right? So the context, if it's the educational context versus a context where, I receive many interesting questions throughout my life at kids' birthday parties about being a mom, and are they yours? So this automatic assumption that I might not have given birth to my children because I'm not able to do that. And continually, even though they are huge, as you can see, they still need to be accompanied by an adult to the pediatrician's office. And I'm still asked, are you their mother? So again, these things take a toll. I mean, we think about this cumulative effect of microaggressions and trauma on people. And I want you to think about that in terms of disability and those microaggressive comments that you might hear or perhaps have perpetrated in your life around disability. My favorite that I've heard probably 3 times this week in a rehabilitation setting is the word lame. People love using that word. And yes, it refers to somebody with a disability, and it usually refers to, oh gosh, the situation is so bad, or I really didn't, perform in that way. So words matter, language matters. Let's think about that. I just want to do a brief overview over on how disability has been conceptualized throughout the years. And again, this might be an overview for some of you, so I'm not going to spend way too much time, but we have different models. Moral models of disability, look at disability within the context of faith or retribution for sin. Again, these are models. Not one is right or wrong. Your job as a clinician and your job as a trainer, whatever role you come to, is to think about the person you're working with or the people you're working with and know how they conceptualize the model. And better yet, how you conceptualize. What is your model? What do you need to challenge? What are you good with? Because we know there are a number of people of different religious faiths who subscribe to the moral model of disability. So while some people might have a reaction to that, it's important to keep in mind what your model is and why it might be important to know other people's models. Medical models, that's what we work in all the time in hospital settings, right? So we know that the best thing on earth is to be non-disabled, and we are going to judge everything and evaluate everything in comparison to being non-disabled. And that, we need to really think about what deficit means and what that means to that person. So what I would challenge those of you who work in medical settings or healthcare settings is what you really need to do is you need to learn how to speak medical model language, and you need to be able to infuse notions of minority model language into that. And the minority model or the social model of disability really just says that the world was built without disabled people in mind, and it's really everything in the environment and people's attitudes that really cause problems around disability. The problem with selecting one of these is that you miss out on a whole lot, right? So if you don't think about the medical or the mental, physical, cognitive difference, sensory difference that somebody has, then you miss out on a whole huge part of their life. We don't want that to be all about what we're thinking about as a psychologist, but we can't ignore it because people will tell you they spend a lot of time managing disability. And we need to bring those models together and see how they make sense for us. We really have moved more towards a World Health Organization definition, which really looks at this complex interaction around, social, medical, and environmental and political factors. So if you think about disability, whatever that disability might be, kind of dancing through the domains of somebody's life, that's how we want to conceptualize it, and how it presents to somebody, how it presents to us as a psychologist, and where does it fit? What domains is it affecting? What domains is it not affecting? What is important to the person in front of us? And what do we need to do a little bit more work on to get closer to having a deeper realization of our own thoughts on this? We really want to think about quality of life and reducing and removing barriers, right? That's what we think about. And for those of you who work in large systems, we think about institutional barriers, right? So it's very easy for somebody to probably look at me and look at my career in the VA and say, oh, she's just sailed right through. That has not been the case. There have been many disability specific institutional barriers that I have confronted, and I have been able to work towards pulling some of those barriers out along with other rehabilitation psychology colleagues and other people who focus on disability to help people get to that level playing field so that those institutional barriers are lifted. But for those of you who, whether you have a disability or another marginalized identity, you know those things don't ever go away. They're always lurking around the corner and you never quite know, will you miss that opportunity because there's somebody on the other side with power who really doesn't get it? I will tell you that people have looked at my CV and not believed that I have completed everything that I have completed. And it's very hard for me to think that disability doesn't play a role with that. So I'll leave that there. How do we as if for those of us who are healthcare providers, I want to share some of this because I think most people think about disability medically and legally, and you have to think about those things as a psychologist, and you need to think about the diversity component of it. I know it's a lot, right? But disability rights are civil rights. The ADA is a civil rights legislation, and the first one to protect people with disabilities. It is this federal statute designed to prevent discrimination and to promote equal opportunity. Not perfect, been revised, we are, but it's what we have. And we look at these issues to how disability interfaces with employment, public services, public and private transportation, and telecommunication services. So again, depending upon what you're working on with a client or a trainee or whoever it is that you're working with, you need to know some of this. And there is actually a specific book on how the ADA affects psychologists. And so if people are interested in that, you can get more information. But you don't just want to talk ADA, because that's what disabled people are used to hearing all the time. Or many organizations will say they're doing diversity training and they're doing ADA training. So we need to know it. It's important. People need to know their rights. I will tell you that the one thing that is incredibly important to keep in mind is that personal assistant services, sometimes we call that caregiving, sometimes we call it attendant care. I just saw something in the media about one of our Paralympic people was denied their personal assistant service attendant to come with them to the Olympics. Personal assistance services was not clearly delineated in the ADA, which causes a lot of difficulties for someone like me who might travel. I don't need a personal assistant in the workplace all of the time, but sometimes when I travel, I do need that depending upon where I'm going. And those things are not clearly delineated for employment. We only know about like 26% of people with disabilities work. That's a whole other presentation. I'll tell you, people want to work. We all love our identities. Some of us like to work more than others probably, but to have the option to do it in an accessible location with having the assistance that you need, all those things in place, and you can actually get to your job and do what you're trained to do. Imagine that. Imagine not having to go through 16 steps to do that. So you need to know the ADA definition just because it's something important for you to know. And again, I'm not going to belabor the point, but physical or mental impairment limits one or more major activities, has a record history of impairment, and regarded as having an impairment. You always want to encourage people that you're working with to save their documentation. And this goes for those people too who have kids with disabilities who go through the school system, have IEPs or 504s. Those documents carry you through college, and it is a great way of having that history behind you to help you get the services that you need for everything that you'll need in life. So there is a history of people with disability having to prove, oh, you don't look that disabled, whether it's a more apparent, I mean, obviously I do, but a more apparent or less apparent disability, and this, again, as part of the stress of like always having to prove, that you have a disability, it's real, and you need that access to move on with your life. So important considerations in healthcare. So patient-provider relationships, so I just want to bring this in. And I know that a lot of you are not healthcare providers, but the data suggests that relationships with providers, is incredibly important, and that, patients prefer providers who are confident, empathic, humane, forthright, respectful. Okay, so we could have saved them some money doing that research, right? Right? It's what we would expect. But do you ask about disability? Because when you do that, you acknowledge something really important for that person. I do a lot of work in sexuality and sexual health. Do you ask those questions? Because when you do that, you are telling that person that you understand that this could be an important part of your life. You're not making an assumption that their disability has ruled their life, but you're asking about it. And you want to know about barriers and what that treatment plan might be. I can't do a VA presentation without mentioning whole health, which has been a guiding principle in holistic healthcare for everybody, for all of our veterans at the VA, and also whole health strategies extending towards employees. For anybody who's been through one of those trainings, you'll have probably been asked to do some deep breathing, to exercise, run around the room, be told that being sedentary takes years off your life. And you know where I'm going with this. So what does that say to me? What does it say to me as a VA employee when I am in those situations and someone's telling me that being sedentary is terrible? And, you know, what about the person next to me who's on a ventilator? Do 10 deep breaths. It is not disability friendly as it is. There are ways that many of us have adapted whole health philosophy, any kind of holistic thinking we can put into it. Doesn't necessarily have to be whole health, but to be thinking about how we broadly adapt anything that we're doing to somebody who has a body difference or a brain difference, right? Anything that might be. So I just want you to challenge yourself around activities or anything that you have done to incorporate experiential learning that's not been accessible to people with disabilities. I'm just going to add some of these, a couple of these quotes in because I find them fascinating. And this is some of the data that's come from messages to primary care providers, but I think it can also translate to psychologists. Disabled folks know primary care providers aren't disability specialists. We want you to take the attitude of, I don't know, but I'm willing to do the work to find out. I think psychologists can use that response too. You can't always expect disabled patients to educate you on everything about their disability. You certainly should ask some questions, but you should do your own work. And we should not be the focus of your curiosity, and that goes for psychologists as well. So we think of a lot of people with disabilities having a huge history of being put on display at grand rounds. That happens a little bit less than what it used to, but it was pretty much, you know, throughout history, normal routine. And I actually was a child who you know, participated in grand rounds at a teaching hospital. Now, I agreed to that, and one of the and I don't know that I was doing it at the time. I mean, my parents agreed to it. I agreed to it, and I had the most amazing physician who, before ever talking about anything to do with my chronic health issues, told them how good I was in school and what my interests were. And if only I had the foresight to know that I'd be coming back to get them with telling them how to treat disabled patients. But right, we want to ask permission. We do a lot of training. I love training hospitals. I love teaching hospitals. You get so many smart people. We get so many smart trainees and all these eyes on, or this vision on one person and one issue. And so it's all okay, but we ask permission. We always ask permission. We always want to be collaborative. Okay, disability is a social identity. So this is the late great Stella Young, right? So, you know, to say that an attitude is the only barrier that we have as facing us, her quote is, "No amount of smiling at a flight of stairs ever made it turn into a ramp. No amount of standing in the middle of a bookshelf radiated a positive attitude is going to turn it into Braille." We need to check ourselves, right? So this is a lot about what we call inspirational porn, which again, that word inspiration you hear keeps coming up, and that is about the fact that, you know, we just change our attitude and everything is fine. Nobody really is disabled because we can do anything. And usually you see athletes with really expensive prosthetics, you know, running in the Olympics, and there's a lot of regard put in that way. Or you'll see a disabled person being taken to a prom by a non-disabled person. And that's all about making non-disabled people feel better. has nothing to do with the person with the disability. It's all to put everyone at ease and say, you're doing a great job. You're doing a really great job taking care of that person. Or what a nice person to take this person to the prom. Or isn't it great you're running the track just like all these non-disabled people? Yeah, I'm being a little facetious, but I want you to check yourself on that, and think about that. Disability competency in our work isn't just a separate culture, it's like another planet. So it's both a social experience and something that lives in the body, mind, and brain. Okay, it's not a layer of experience that can be easily separated out of into interactions. So I just want you to think about that for a minute and think about the ways that you've incorporated disability into any of your diversity, equity, and inclusion teachings or trainings, or how you've conceptualized patients, to think about this a little bit more than just that mind-body difference. Disability culture has been talked about in a variety of different ways. Dr. Gill is she's a disabled psychologist who was one of my mentors in the early 90s. But some of the tenets around it, just to share with you, because we'll say, what's disability culture, right? There's no food. There is a food, that's whatever it is, it's easy to arrange for, to make sure that you have assistance with, that fits your dietary restrictions, and on and on. But kind of this matter of fact acceptance of, or matter of fact orientation towards assistance, usually with people who've lived with disability longer. Sometimes we have people who have newly acquired injuries, and it really is difficult to ask for help. It actually is one of the things that irritates me the most about non-disabled people, because I've been asking for help all of my life, right? So everybody should be comfortable with that. So I have to check myself and take a step back and know that I ask for help all the time. And it's very matter of fact to me. This acceptance of human variation across the board, things are different. Things don't surprise us as much, right? The tolerance for being unpredictable, being pulled out of someone's life, and not being able to access what you usually are used to having access to. Disability humor, it's tricky. There's in-group humor. There's certainly out-group humor. There's humor that is okay for disabled people to share with certain allies because they know they get it. Managing multiple problems. You're always dealing with systems and healthcare and your own job and your own accommodations, and just to be thinking about that globally for the people that you work with. Having a sophisticated future orientation, right? Because your life depends upon assistance, perhaps assistive technology. You got to plan those things. So with my travel schedule years ago, I would know probably 2 years in advance where I was going, who was going with me, what I needed, what arrangements I needed to make for my own health or for my kids or whatever that might be. And my favorite, a carefully focused capacity for closure and interpersonal communication, which is a very important way of saying, you know what, you're not, disabled people are not put on the earth to be educators 24 hours a day, 7 days a week. And sometimes people say offensive things, and you have to have a way to close that off. Obviously, in a situation like this, if someone asks me a question, it's an educational context, I'm going to answer that. And I'm going to go forward with that. But in a social situation, when I am just being a wife and a mom and a friend or a family member, I don't feel the need to always educate. There's a hangover that comes with that, right? Because there's that hangover comes over with, oh, is that person going to buy into this bitter stereotype? Or, should I be pulling out my resources to kind of be there? So it doesn't come easily, I think, all of the time, but we certainly need to have permission to do that. And a flexible adaptive approach to tasks. So I always love that tenet, and that's another one that goes with sexual expression for people with disabilities, because whatever creativity that we come up with, with needing to do with in our typical lives, those things can be expanded to anything, including relationships. So I just want to touch a little bit more deeply on cultural competence, right? So these are the things that we think about with cultural competence: awareness, knowledge, skills development, and practice and application. Knowing that practice and application are usually the most difficult to get to. 1 and 4 are my favorites. I think, knowledge and skills development, we can all do that if we put ourselves to the task. And practice that application. Why is that so difficult? you and I all know behavior change, trying to get people to change their behavior, especially people who have been in the field for a long time, right? Like we're surrounded by these incredibly smart early career psychologists. We need to listen to them. We need to think about their points and figure out how we integrate new notions and how we read about new things in psychology and diversity and how we integrate it into our work and into our practice. Some very small amounts of information in psychology on the conceptualization of people with disabilities and cultural competence. There are obviously similarities to other minority groups. There's a shared history of discrimination and oppression. And we're different, right? These issues related to accessibility, medical symptoms related to, chronic health issues, those types of accommodations makes it different. Also, people with disabilities are many, not all, are used to growing up, if they grow up with a disability, in a home where they're the only person who's disabled. There are some communities where we see more of a disability lineage, but a lot of times it can be an isolating experience. So as we kind of get to our clinical area here, so, you all know this APA policy statement on evidence-based practice, right? That, that we learn these strategies. Why do we learn them? Well, VA especially wants us to have, well, the patient needs to have choice. They need to have choice with what's going to work for them, and that we integrate what we know works within the context of culture and preferences. How often do we do this? I hope that we are doing it all of the time. I don't know how often we do it with disability, right? So as you sit here and you think about, oh, CBT is my go-to intervention, or, ACT is my go-to, really, are you thinking about thoughts, feelings, and behaviors within the context of the disability experience? Are you thinking about values and clearly value shifting that occurs around disability and how that plays out in someone's life? That's what we really want you to be thinking about. And a way to do that is my very good friend, Pamela Hayes, amazing multicultural psychologist, the first multicultural psychologist to put disability anywhere in the writings. And so I'm so thankful for her. So for those of you who haven't seen the addressing framework, right, this is one way to always kind of integrate disability into any of the work that you're doing. You just put this acronym at the top of your clinical intake or any role that you have where you don't want to miss anything around diversity. Now, the one thing I'll call your attention to is she has two D's in here, and the two D's are really great because it makes the acronym really nicely. And upon discussions with her, I pointed out to her, it's a little medical model-ish, right? So we have developmental, acquired. We don't see that with the other categories here. So really, we're not going to change. She is aware of that, and when I present on this, and she's aware of that. And sometimes we just need to roll with it, right? It is there, and I am so appreciative that this model acknowledges it, and it helps us as clinicians, psychologists, and educators to think about disability diversity. So again, this is something I always use with training. It's something I always use in my own work with the limited amount of clinical work that I continue to do. I want you to think, for those clinicians out there, about every step of your process with disability and assessment, from your interview, your appearance factor, everything, that your instruments, your norms, how you conceptualize and how you think about diagnoses. It is so important for you to capture the full disability experience when you're providing clinical services to this population. All of these things can be influenced by these social barriers that are in place. So if you see somebody, we say, oh, someone has diminished personal hygiene, right? We look at someone's appearance, we comment on it. Are you asking that person if they have enough personal assistance at home or somebody to assist them with activities of daily living? Are we looking at measures that are applicable to somebody and a way to implement those measures with folks who have different bodies and different ways of thinking? is your goal to do a standard assessment, which I always say whatever your supervisor says is the right thing, but really it really becomes around clinical questioning to me. If you want more data, you get that data, but you do it in a way that is going to bring you some good results, and something that you truly can say that you're measuring and help this person to get along. So I'm always about altering and adapting anything that needs to happen in those situations. With case conceptualization, obviously, evaluating your own personal views around disability and the models of disability, how those things, interact, and to always know that, and we can even take this out of the clinical realm, but to even think about with trainees, right? We have a trainee with a disability, what, how much important is that to that person? So for clinical issues, it's not always related to the presenting issue. So as it is with people of color or other people with other diverse identities, it's important to know that diverse experience, but that, are you treating kind of run-of-the-mill depression, run-of-the-mill anxiety, or are you doing specific work around ethnicity, race, disability, sexual orientation? It takes that clinical eye for you to kind of determine those things, but what's the point of this is to make sure that you are incorporating those questions into that. I just want to bring up these disability affirmative therapy, which is really, this meta framework around, and it's similar to other, affirmative therapy. So if we think about LGB affirmative therapy and how those things are important, it's a meta theory. And I think it's important to think about what that meta theory is and how you can place your evidence-based treatments within that meta theory. Right. So if we look at, guiding principles for a disability affirmative therapy, we're looking at a framework. Is it, looking at this bicultural, multicultural intersectionality of identities with people? Is it, we often say disability is a family affair because whether it is a family of choice or a biological family, when people love you, it affects them. When you have disabled people have new friends or new colleagues and they go out with you to a conference or wherever it may be, and they are affected by that level of stigma, they become part of your world and they become part of your advocacy, and they feel that pain as well. So thinking about whether you need additional skills and how you conceptualize things. Okay, so let's just breathe and reflect because I realize that we are getting to the end here. And I just have a couple other comments to make around all of this. And that is similar to other diverse identities, we need to embrace the discomfort of disliking our identity, right? This, as I've said before, this is not an easy uh, experience to have in life. If social justice, kind of went in a different direction around disability and for other groups as well, we might be saying something different. But because of that, there's a ton of internalized ableism, which is actually a new chapter that I'm just wrote with a bunch of fabulous colleagues on internalized ableism and how to treat internalized ableism. But, we need to embrace the possibility of accepting that non-preferred aspect of disability, or when people are having a bad disability day, or, we have to see that accepted as non-preferred rather than, having people, risk this inauthenticity to be self-accepting. We like it when we see people get to a place where they feel more comfortable being who they are. But is it always the goal? Is that our treatment goal? And do we have treatment success if somebody accepts themselves better? I think it's about being there for that person and understanding it and knowing that there are going to be difficult times, whether it's disability or other marginalized identities. There are bad disability days. There are days that we are rejected for jobs that we knew we were qualified, but we knew that people had questions around our ability to actually execute the job. There are times when we can't access social events with our family. We rarely can go to other people's homes. And that's a terrible disability day for me when I can't go see my kids get their sports awards because that event is at someone's house and there's no other place to have it. That is not a day that I'm flying high on disability pride. That is a sad day for me. So there is, this is adaptation to disability is not this finite process. It's a layered experience, and it shouldn't, idealize or pathologize aspects of adaptation. It needs to allow for this truly empathic response. And that's what helps our therapeutic alliance. It's what helps our alliance with trainees, and it helps us with any relationship that we have in um, our professional community. Where do we go from here? I think it's about, personal perceptions. I think it's all of our responsibilities as educators, clinicians, and researchers. I think if, you know, as with other diversity and inclusion and equity issues, I would like to think that most people want that information, but we all know that some people want it more than others. And I don't think we're at a point in life right now where as psychologists and as a field, we just say, okay, that's okay. You choose whether you want to explore this or not. It is supervisors and managers' responsibility to really invoke intentionality around this and to say, this is, the expectation is that you are exposed to this information. A lot of people don't agree with me on that. They want this kind of natural occurrence of people being drawn to these issues. And I'm fine. I like it when people disagree with me. But I have really found in the data that I have read in terms of the success of diversity inclusion issues in the corporate world has been tying it to people's performance appraisals, tying it to mentorship projects where people in different organizations are paired with diverse people. Those things work. They work with seeing more diverse people in those companies, and they often work with people challenging their perceptions because they are put into a situation that they wouldn't naturally put themselves in. So I think that we have an ethical action or a call to action to be ethical and responsible and to explore these belief systems around disability. That is my dog. That is Jackie Robinson Mona Hunter. And so because I have the kids in, he's my fur baby. So he has to always kind of end my presentations now because I've spent so much time with him at home this last year and a half. So I am happy. This is where to find me. You can find me in VA email. You can reach me by phone. You can find me anywhere online, any social media outlet. I'm happy to discuss these issues with you further and help you in any way that I can with becoming more culturally competent around disability. Thank you.
As usual, Dr. Mona delivers. That was so super fabulous. We do have one question in the Q&A box from Xiao Wen. I hope I said that correctly. Can you offer some recommendations in terms of whole health that will keep people with disabilities in mind in regards to, and actually, I had the same exact thought. I thought, oh my gosh, this is like, definitely something I knew, I learned today, in VA, the whole health initiative has been upon us. And I have to say, I hadn't even thought about that. So thank you so much. I feel, very embarrassed that it didn't occur to me before, but I love this question because I think as we move ahead and try to help veterans engage with their own sort of personal health, whole health has really been emphasized. So anything else you can add about that would be great.
Yeah, and it's the thing that I've gotten the most questions about. So I will tell you, I've been trying to work with the whole health people for years now, making suggestions about their models, making suggestions about trainings, and I haven't been able to get much anywhere. And I don't think it's because there's a lack of caring. I think this really calls for a fundamental shift in everything that they do, like everything that they write and every everything that they are trying to convey. So I will tell you, and I am blanking on her last name, Sarah from the Houston VA, who is a rehabilitation psychologist. Their last name starts with a B. I can't think of it. But Sarah is somebody who, she actually took the PHI, the personal health inventory, right? There's like a short version of it. And she adapted it with questions that were more specific around disability, right? So whole health can be, there's two components to it, one of which is the personal health inventory, which focuses on, healthcare providers saying not, what's the matter with you, but what is important to you and what do you value? So that requires a culture shift with all of your primary care physicians and everybody else. And so that's part of it. And those questions are like, do you like biking? Do you like doing this? Do you, all these activities, like, oh my gosh, this is very ableist, right? Like we just, and there are things that can go in there. We can adapt this. So I have looked at the PHI, and I've always wanted to revamp even my own department and had plans to do that. But people have had other plans for me. So I haven't been able to allocate my time in that way. But I think you look at the PHI, you look at changing the questions and you make it meaningful for the population that you have. I think using, strategies, when you look at a patient that you're working with and that person has breathing issues, you're certainly not going to, they're on a ventilator or they're trached or they need suctioning. That's pretty normal in rehab psych. We don't focus on breathing. Obviously, we focus on imagery. Is that an option? Is imagery an option? Is basically just, feeling grounded? Is it going and, looking at the garden and seeing a beautiful flower, right? There's so many different things that we can think of to help people get out of their head and get into their, kind of their whole being. Disabled people are so used to divorcing themselves from their body, right? They don't like their body. The body does not cooperate, or their mind. And to figure out a way to bring that back in is something that I do as in the past I've done as a sex therapist, right? Because people are so divorced from their body. You start talking to them about somebody touching them. It's such a foreign concept because they're always touched objectively by medical providers. And so it's very different. And I actually will say I was just personally reminded of this. I had 5 days of vacation. I can't believe I went to Vegas, but I did go to Vegas to support my friend's daughter in a dance competition. But while I was there, I went for a massage. And interestingly enough, this would only happen, right? This is not coincidence. It was meant to be. This person was the person who I got was a veteran who had worked at my VA or had gone for services at my VA 14 years previously and gave me one of the best massages of my life and was so thankful to be able to give back to civilian provider. And in the context of that, that was such a spiritual experience for me, right? To have this massage from somebody who, this mission that I've served like all of my career, and also reminded like, I haven't had somebody giving me a massage like this in a long time. And I forget, like when you are using a wheelchair, there's certain parts of your body you don't feel as much or they hurt all of the time. To reconnect with that in a positive way was so healing. So I just think looking at those individuals, figuring out a way to get that mind-body connection going in any way that you can. And I'm happy if you all want to contact me, I can share the version of the PHI. Somebody said they missed my email. It's just Linda, linda.mona@va.gov. So yeah, so I was reminded here. I talk about these things all the time. Like, oh my gosh, I don't, usually have people touching my legs, right? Because, and then not only that, is a person a healer, right? And bringing me back into my body. We've got to figure out a way to get people in touch with their bodies and their minds and those parts of themselves that they have wanted to run away from because it has caused them so much pain, right? There has to be an in-between place. So I hope that's helpful.
That was super helpful, and your story was really touching. I think that's so super cool. It's one of those sort of full circle.
It was amazing.
Stories and experiences that, yeah, I think we all hope to have as psychologists. We're going to have to end there. People are going to hop off to their next thing. Linda, as usual, just a stellar presentation. Thank you so much. I don't know if you can read the chat. I'll leave it open for a little bit so you can read all of the cool stuff that people have been saying about you. If you're still on and you're wondering about your CEUs, I did post that in the chat, the SurveyMonkey link. Everybody who was registered will get an email message anyway with the survey link. We would like you to complete that by the 24th so that we can process your CEU credit. And I'm going to stop the recording now.